Good evening, everyone. Thank you for the invite. My name is Jose Romero. I'm from Guatemala. I will present soon and late in ocular trauma 2 cases. There's some pictures of my country. We have the Mayan ruins from Tikal.
Sorry, sir.
Your slides are not moving.
You should visit. No?
Your slides are not moving.
Slides? No?
We can see your slide, but slides are not moving. So make a slideshow.
Okay,
Go to slideshow, sir.
You can see the moving.
No, it's not moving.
No?
Dr. Mel, can our admin help him? Sir, please unshare and share again your PPT.
Unshare and share again the screen.
Okay.
Dr. Jose, we can still see your screen. Could you please stop sharing and share again?
Okay.
Yeah. Please share again. Still loading.
Yeah.
Can you try moving to the next slide, sir?
Can you see it now?
No.
It's
Looks
not
like
moving.
we are on the same slide. We can just see the first slide.
Go to the
Okay.
slideshow first. Maybe it would move then.
Okay.
Sorry to interrupt you, sir. Sir, please open your presentation. Yes, sir, perfectly fine, sir. It's visible.
Yeah, it's fine now.
Can you move to the second slide, sir?
Yeah.
Yes.
Okay,
perfect.
now.
Over to
Yeah?
you, sir. Yes,
Yes.
it's moving fine.
Thank you.
Okay.
Back to you, sir.
So there's some pictures of my country. You should be more welcome to come. So taming, ask yourself what is being done, how it is done, when to close the wound, and does it need a vitreous surgery? If so, when? Why we should run is about prevention of endophthalmitis. Closing the wound doesn't eliminate contamination, but it does prevent any secondary contamination. And about the expulsive hemorrhage, not specific data for ocular trauma. There is a lot of data for keratoplasty, but in the logic, it should be exacerbated by length or external pressure. Delaying wound closure more than 24 hours at presentation increase the risk of endophthalmitis. So all open wounds should be closed as soon as possible. When intraocular foreign bodies treatment is more than 24 hours, there's an increase of risk of endophthalmitis. There's two studies that compare itself from 13.4% versus 2.3% when the treatment was more than 24 hours. The rural setting is another risk. It is reported that cases from 9.5 to 37%. The dirty injury has a OR of 5.3. As well, the lens capsule rupture has an OR of 0.44. So if a patient comes in extra office hours, you have two options. Wait for office hours, but you have the risk of secondary contamination and risk of explosive hemorrhage. Equipment, or not having all the experience and expertise, but maybe I think immediately is better. if you have all the experience and all the equipment ready, but sometimes it's not possible. In the first case, we have a 6-year-old female who had a hit in her left eye with a wood stick 10 days ago, with a BA of 20/20 in the right eye and a hand movement in the left eye. And also, unfortunately, 4 days ago, she started with a chickenpox. So in the exam, the patient had a crusty and bullous lesion on the eyelids, 3 millimeter full thick corneal laceration, negative sidle, no AC, cells 3+, and traumatic cataract. The treatment decided was atopic moxifloxacin every 3 hours, prednisolone every 3 hours, and oral prednisolone and amoxicillin clavulanic with a bandage lens. Pediatrics recommended a 6-day delay for the surgery for possible airway inflammation. So she went to surgery six days later, so 16 after trauma, 10 days after chickenpox. A corneal wound repair plus a lens aspiration plus an anterior vitrectomy was performed. The first day post-op, visual acuity of contour fingers, IOP of 26 for eye care, with a mild corneal edema, negative sidle, permeable PI, and aphakia. 1 month later, a 3-piece IOL in sulcus was performed. And 15 days later, the visual acuity of 20 was reached with this refraction. You can see the cornea with the scar and IOL in situ and posterior pole okay. In the second case, we have an old male of 20 years old, a 20 years old male, sorry, came to the ER at 11:30 a.m. after a car accident, hit by a driving mirror with a visual acuity of 20/20 and 1/200. The IOP was digital low. In the ultrasound, it showed a hemivitreous and attraction to a wound. But unfortunately, he just ate. And our anesthesiologist leaves at 15 hours. So we have to wait until the next day. We have some pictures of the case with a scleral full laceration with a triangular shape with vitreous in the wound at 6 millimeters from the limbus. The next day, this surgery was performed. First, the peritomy, you have to be like very careful not to do so much pressure because there's a lot of bleeding around the wound. You have to use cautery, vitrectomy in the wound. Trying to not do more harm. Later, the repair, I use 7-0 Vicryl. First, I do the technique of zipper or close as you go. Very careful to see the extent of the wound. Then I check under the lateral rectus. There's no more wound. And I start with vitrectomy. I do the vitrectomy, all the periphery to cut all the traction. He had a little of hemivitreous, and I did DVP to finish all the traction. And the case end like this. In the first day post-op, the visual acuity improved from 1/200 to 20 200, IOP intense, ciliary injection, retina okay, and rest normal. The follow-up 1 week later, the visual acuity by pinhole was 20/20, ciliary injection, retina applied. And the message, close globes as soon as possible. Sometimes it's not possible immediately, and do an integral management. Thank you all for the invite.